that provided trauma-informed care training throughout San Luis Obispo County for many years. We've been meeting as a group for at least 3 years now, doing focus groups and assessments to really determine what's needed in our community to move trauma-informed care forward. And as a learning collaborative, we're in our next phase right now, and we're so excited to really launch that and continue that movement of learning with Dr. Diana E. Ramos today, our Surgeon General. So before we get started here, I want to ask you if you want to put your name and organization, if you're affiliated with an organization, into the chat, please do so. It's great to know who's here. If you want to make sure that you're invited for future presentations or trainings, feel free to provide your email in the chat as well. Or you can email me and I'll put my email in the chat. We are very excited to move forward with our meeting today. But as we like to do, we like to share our shared agreements that this group has accepted and also provide a land acknowledgement. So I'm going to pass to my colleague, Michelle Simone, for our shared agreements.
Thank you, Barry. Hi, everyone. Michelle Simone. I'm a part of the Trauma-Informed SLO Steering Committee, and grateful to see many new and familiar faces here. So I like to read this from a place of kind of reflection and possibly even a grounding way to ground. So these are our shared agreements or commitments. The first one is, in this work, we hold inclusivity and respect for our diversity of perspectives, intersecting identities, backgrounds, cultural frameworks, communication styles, role status, and experiences. We understand that psychological safety assumes positive intent, taking risks, making mistakes, learning with humility, and investment towards repairing any harm caused. We welcome hard conversations and aim for our communication to be psychologically safe, productive, and effective. We welcome each other's voices with equity and transparency. Those of us who contribute often can also make space for others, and those who contribute occasionally can take space by sharing more often. Within our agenda, we rely on the use of a parking lot to record new and important ideas for follow-up at a later time. And finally, we welcome each other by acknowledging our shared mission to utilize and promote trauma-informed principles and increase wellness in our agencies and in our community. And as we take a breath together, I'm going to pass it over to Rebecca.
Hello, everyone. Welcome. I'm Rebecca Parham, and a continuing member of the Trauma-Informed Care collaborative that we have here. I'm going to speak to our land acknowledgement. And so it's another opportunity to ground and get oriented as we get settled here. Welcome, everybody. Welcome, Dr. Ramos. This is a very exciting time that we have together today. So our land acknowledgement is as follows. We support efforts to affirm tribal sovereignty across what is now known as California. We respectfully acknowledge that we live and work in territories where multiple indigenous nations and tribal groups are the traditional stewards of the land that they have called home and whose ancestors have resided here since time immemorial. We acknowledge the trauma caused by colonialism and seek to find actionable and skillful ways to contribute to the healing and reconciliation in the present and for future generations. And it's a lovely moment for us to have to speak to that, because we have the past and we have the future. You know, all of that continuum is important. I'm going to pass to Barry at this point for some housekeeping and to get us started.
Thank you so much, Rebecca and Michelle. So yeah, just a couple of housekeeping comments here. We are going to wait for after Dr. Ramos's presentations for any questions you may have. She will be answering those. You can put those in the chat beforehand if you like, or we'll have the ability for you to raise your hand after the presentation. There's many of us here, so we're just trying to be as organized and coordinated on that as possible. And then, of course, please do stay muted throughout the presentation. And then we look forward to having conversation with Dr. Ramos afterwards. So I have the absolute honor to introduce Dr. Diana Ramos, California's first Latina Surgeon General, a physician and public health advocate with over 30 years of experience, appointed by Governor Newsom to serve as the state's leading voice on urgent health challenges. Dr. Ramos is the recipient of the 2025 All Children Thrive Public Health Leadership Award, as well as the 2024 Latino Spirit Award for Achievement in Public Service and Health. As an OBGYN, Dr. Ramos brings a deep understanding to her priorities, protecting reproductive health, tackling toxic stress and adverse childhood experiences, and ensuring equitable care for all Californians, particularly women, children, and communities of color. A fierce champion of trauma-informed care, we are very excited to welcome Dr. Ramos to our community.
Thank you so much for the opportunity to be here with all of you. And I took the liberty of pulling some data that's specifically to San Luis Obispo, knowing that perhaps you may be interested in knowing how your county is doing, your region is doing compared to California. So let's get started. Next slide, please. I have no disclosures, and the next slide. So these are the objectives, and I understand that the group is very well versed on ACEs. My hope is that we can review the importance of addressing adverse childhood experiences and toxic stress, but then more importantly, taking it to the next level and seeing upstream approaches for prevention, starting with the perinatal time, and how that can actually leave a longer time impact in terms of lifelong health. So let's get started. I want to start out with this case study that was shared by Dr. Vincent Folletti. For those of you who are not aware, Dr. Folletti was the principal investigator of the ACEs study that was conducted at Kaiser Permanente, San Diego, back in the late 1991, I want to say. Dr. Folletti had a weight loss clinic. He's a preventive medicine physician as well as an internal medicine physician, and they were running a weight loss clinic, ketogenic clinic. And he said, this is an example of what I saw. Started out with a 28-year-old patient that was over 400 pounds, and the intervention worked, going through the diet, advisement, lifestyle modification work. 51 weeks later, the patients would typically lose a substantial amount of weight. And in particular, this patient went down to 132 pounds. Now, he said shortly what I would start to see is that the patient would start to gain the weight back again. And he would share, I had no idea what was happening, but this was happening over and over again. And he said, finally, I just had to stop. And I asked, is there something I should know about the weight gain that is happening again? Something that maybe I'm missing? Is there something I need to understand? And he shared that it kept on coming up over and over again. He said, one patient, this one in particular, when she was 8 years old, she was thin, pretty, and that's what her father would say. You're so thin, you're so pretty, and he would sexually abuse her. And this continued on. It continued on so much that she had a younger sister, and she would encourage her sister to overeat. Because what started to happen is when she started to eat more and started to gain weight, the sexual abuse stopped. And she was encouraging her younger sister to do the same, to overeat so there would be no sexual abuse for her. So this is what started the realization of, well, there were things that were happening in childhood that perhaps are impacting the weight gain here. And he went on to share that the patient said, the weight was actually protective for me. The weight shielded me from all of the negative experiences that I had as a child. She went on to say that as she had continued to lose weight, when she was about 132 pounds, as you see in the picture, she was being sexually abused and her boss was coming on to her. Her boss was married, and she said, it's happening all over again. And this is where the ACEs study started. This is where asking the questions, trying to understand the reason as to what happened in childhood, that the realization came about that there's opportunities for us to make a difference when it comes to lifelong health. Can I have the next slide, please? So we, again, as a recap, know that ACEs fall into 3 buckets. They fall into abuse, neglect, and household challenges. And you can see here how they come into play. The thing I want to really highlight is the fact that the household challenges are probably things that we have all experienced to some extent in our lives. And that falls under mental health disorders in the household, as well as divorce, separation, if somebody is incarcerated. And we may think, wow, this is actually an ACEs. Yes, it is. So, and as a Surgeon General, I have to address adverse childhood experiences. So I had to come up to speed on ACEs and everything about ACEs. And I realized, ACEs are just the way that we, the term for what we call life. This happens to all of us to some extent or another. And we have to ask, why is it that some people do better and some people don't? Next slide. So we have to also remember the other components that are happening besides what's happening in that child's life, besides what's happening in the home. And that's environmental as well as community. And you can see here, this is from the CDC website, which is a really nice summary of the environmental forces that really help mold the experiences we're going through as a child. So they can be climate changes. And here in California, not too long ago, a year ago, it was the fires. Also, it could be earthquakes, right? All of these natural disasters, the pandemic, that really play a role in how we respond to these ACEs, as well as community, what's happening. And these are basically the social determinants of health. So what's happening in terms of food insecurity, economic status, housing, all of these things come together and impact the way that we respond to the adverse childhood experiences. Next slide. So there are 3, and this is from one of the early publications as to what do you do with ACEs? How do you treat it? And you can either prevent, and this is hopefully by educating ourselves, we can prevent it from happening. We can either then decide, and hopefully this is what all of you are doing right now, is providing key practices. So providing medical homes, screening for ACEs, implementing trauma-informed care. I mean, the list goes on, you can read there. And then specialized care, meaning that when extra care is needed, extra attention is needed, that resource is provided. And some of that could be from mental health, substance abuse, cognitive behavioral therapy, and more. So these are the 3 major ways that we can approach ACEs. Next slide. So what's happening in San Luis Obispo? So these are the ACEs screening rates in your county. You can see your county with the little star, and thank you so much for my team, Musca, for highlighting San Luis Obispo. But you can see that in San Luis Obispo, the screening for ACEs is 14.2%, and then and that's for 0 to 20-year-olds, and for the older population, it's 1.3%. So you may or may not be aware that screening for ACEs can can be done by anyone. A person can do it on their own. But more importantly, if it's done by somebody that has an NPI number, the National Provider ID number, you can actually get reimbursed if you are have your NPI number. The Medi-Cal rate is $23 to screen and then to be able to go on and provide support. So, and I just want to highlight how you all compare to the rest of the state. The darker colors are the areas that are screening more, doing more ACEs screening. So there is an opportunity to have those colors become darker and obviously screen more. Next slide. So what are the most common types of ACEs that are seen overall? And you can see that some of the top three are verbal abuse, followed by separation, divorce, and then followed by household substance abuse. So these are the general overall most common types of ACEs. And it's important to know so that we can, one, alert those that we counsel are in partners with their health and let them know if we hear something in terms of verbal abuse that's happening, just to make them aware. Oftentimes we replicate the type of communication, the type of environment that we ourselves grew up in, and we need to just identify what's happening so that we can break that cycle. Next slide. So what are the prevalence of ACEs in California adults? I showed you the screening rates overall for San Luis Obispo, but in California in adults, 7 in 10 have at least one ACE. Remember I said that ACE is really, the way that I saw it, was a term for what happens in life. The other thing to highlight is that 1 in 3 youth report at least one ACE. So for those of you who are not familiar with the ACEs screening, it's 10 questions. And if you screen yes to 4 or more questions, that's considered the toxic level, the level that can have more negative outcomes. So can you click on the next one, please? So what about those 4 or more? This is that toxic level. So 1 in 5 adults reports that they had 4 or more ACEs growing up. And 1 in 25 youth report 4 or more ACEs. So this is the toxic level. Next slide. So in San Luis Obispo, you can see how it breaks down here. In terms of adults, you can see that you have a higher rate than what is seen in general in California, with your rate being 26%. So this is in adults for having 4 or more. And this is an opportunity for improvement, and the rate for 1 or more is also high. So the first thing in order for us to improve is to identify, to screen, so we know where our starting point is. And then most importantly, this is where I would lean on all of you to help us improve these, the numbers, so that the next generation will have a lower rate of ACEs that they experience in their life. Next slide. So you may or may not be aware that ACEs do not affect everybody equally. If you are of lower socioeconomic status, you have a higher probability that you have a higher level of ACEs. Women, low income, LGBTQ+, Black, Latinx, Indigenous, people of color have higher risk for more ACEs. And discrimination experienced by those same groups, including racism, is also a risk factor for toxic stress. Next slide. So in terms of the ethnicities of people who are experiencing those 4 or more ACEs, remember this is the toxic level. You can see that the group that has the highest, and this is California specific, are the American Indian, the Alaska Native population, with 34% having 4 or more, followed by people who identify as 2 or more races, but then African American and Hispanic And when you compare that to the statewide average of 20%. So knowing our starting point is important so we can know where we need to focus and perhaps implement tailored approaches to these ethnic groups. Next slide. Now, the positive thing, and I like to focus more on the positive, is that there are things we can do to mitigate the adverse childhood experiences, right? And I say that because we know that the more positive experiences there are, the ACEs diminish. The negative stress, the epigenetic changes, all can be prevented by doing positive things. So 6 to 7 positive things can really mitigate bad things happening. Now, you may or may not recall that the previous slide had the Native American population with having the highest number of ACEs. But I want to point out the fact that it's actually the American Indian, the Native population, that have the highest number of positive experiences. So even though they have the highest number of ACEs, they have the highest number of positive experiences, which is really good. Now we just have to go back and think about, wow, what would things look like if there weren't enough positive experiences? The other population I want to highlight, and it's written here, is that Hispanic adults have the lowest prevalence of the positive childhood experiences. Now, this is really important because in California, 40% of the population is Hispanic. 40%. So if we're talking of a good group of a population is not having those positive experiences, you're going to see all of the potential negative things that could come out if we don't encourage more positive experiences. So this is a call for action. Next slide. We know that if we have more positive experiences, there are really good outcomes all across in terms of what is available from easy things that can be done, from having family standing by people during difficult times, feeling safe. These are some of the examples of the positive experiences. And the most common one is feeling safe and protected at home. So these are ideas. These are things that we can all do, bring awareness to, encourage at home to do for positive experiences. Next slide. The other thing to realize is that the more positive experiences we have, the healthier the self-reported health status. People who have more positive experiences say that they're healthier. And this is critically important because we need to mitigate all of the potential negative outcomes that there are. Next slide. One of the easiest ways to have a positive experience is simply by having dinner together. And yes, that this is an easy way to create those positive experiences, because this provides an opportunity for communication, an opportunity to feel supported. You know, we can go down the list that I showed previously. It just sets it up and makes it more easy to do. I do encourage that everyone put their phone away, everyone focus on the conversation and not have the TV on. So that truly would make conversations more impactful and meaningful. Next slide. So if we address ACEs, this is what we can potentially decrease. And this is from the initial data that was done from Dr. Vincent Folletti's research along with CDC. You can actually decrease depressive disorders by 44%. Let's stop. You can decrease depressive disorders by 44%. The best medication really only works to put people in remission if they have depression 50% of the time. You don't even need medication. So this is why it's so critically important for us to really encourage those positive experiences, to screen for ACEs so that we can divert and make an improvement on these health outcomes. Chronic obstructive pulmonary disease decreases by 27%. Asthma, right? How many times do we not hear about childhood asthma? Decreases by 24%. You can see all of the rest as well, from diabetes, obesity. Next slide. And then other social impacts as well. You can actually prevent smoking 33%, drinking 24%, and then improve some of the social challenges that many people experience. Now, if you're like me, I would say, how can this happen? How can this be? What's the correlation? And for me, like, what's the mechanism of action here? And really, if you start to think about it, it makes sense. What happens when we are stressed, when there's bad things happening in our lives, especially as a child, when you may feel like you have no control and helpless? Maybe you're going to eat to feel better, and pretty soon those choices may not be the healthiest, and you're going to begin to overeat. And then that overeating becomes a habit, and you start to gain weight, you start to become obese, and it just continues to perpetuate. It could be that instead of food, you're choosing to smoke, to drink, you're choosing to use illicit drugs. And so all of these things together really come into play to change that lifelong trajectory. This is why we need to address adverse childhood experiences so that we can improve and increase the number of positive experiences, and more importantly, make a difference in lifelong health. Next slide. So for those of you who are not trained in ACEs and you want to be able to bill, please, this is the QR code for a 2-hour CME course that after you take it and you'll get a certificate, you can actually then screen and get reimbursed for the screening. And this is just a summary of the total number of people that have completed the training since the inception of the program. And more importantly, you can see that before the training, a smaller percentage of people did not screen, but after the training, over 63% of the participants screen for ACEs. You start to make a difference. Next slide. So we're going to play a video that's going to set the groundwork for the next phase of the ACEs that we're bringing it back, and that's to the adults.
Every journey toward parenthood starts long before pregnancy. It's about dreaming big, planning, and imagining the future. But what if your past experiences could shape that future in ways you haven't realized? Adverse childhood experiences, or ACEs, which include tough moments like family struggles, neglect, or difficult events, can affect our health even into adulthood. When a pregnant person has lived through ACEs, whether due to poor mental health, stress, tough experiences, or lack of support, the impact can ripple across each stage of their child's development. Unaddressed ACEs and untreated life adversity before and during pregnancy are linked to complications like preterm birth, low birth weight, poor nutrition, and difficulties bonding. These early challenges can create long-term consequences. But here's the inspiring news. The first vital sign of pediatrics is maternal health. Recognizing and dealing with ACEs early, especially before pregnancy, can dramatically transform you and your baby's future for the better. With the support of caring, trauma-informed healthcare providers, you can build resilience, gain tools to manage stress, and confidently step into your journey toward parenthood. Addressing ACEs early means breaking cycles of stress. It sets you up for success, helping you become the kind of parent you dream of being, and creating healthier, happier lives for your future children. This isn't just about changing your own life. It's about making waves of positivity that ripple through your family and community. With support, connection, and early care, parents can change the path forward. Let's make talking about ACEs a normal part of preparing for the future. Together, we can create a supportive environment that celebrates strength, resilience, and health. Every action today shapes the tomorrow we dream of. Address ACEs now and build a healthier, brighter future. Learn more at osg.ca.gov.
Next slide, thank you. So, one of the initiatives that I am committed to is to decrease maternal mortality. Maternal mortality is 86% preventable here in California. We can prevent moms from dying. As an OBGYN that I have been trained to be, this is really a critical opportunity for me to elevate. And so we can start before a pregnancy even is conceived. And that's what's called preconception health. And ACEs are preconception health. ACEs are a way for us to really identify who is going to need more care. And that is, as you saw from the abuse, the history of abuse, neglect, and the household challenges. And as we saw, and this is documented in the literature, that a person who has higher ACE scores have higher unintended pregnancies, higher risk of hypertension, preterm birth, postpartum depression, and the baby carries the imprint of the stress exposure for the rest of their life. So this is an opportunity for us to really make an upstream difference before any of the negative stuff starts. And then more importantly, this is an opportunity for us to help the mom. Next slide. This was published in the American Journal of Obstetrics and Gynecology. This report, this paper highlights the fact that really when we support the ACEs screening in the mom during prenatal care, it really makes a difference in terms of early intervention services, referrals for her, and if we think about it, for the baby and the whole family. So just validating what we are already proposing. Next slide. Also important to keep in mind that when we screen for ACEs, it's the beginning of getting better care. This was published from LA County's experience. There was increased access to healthcare. They actually went to get more medical care, and they also did the preventive primary care as well. Next slide. So again, an opportunity for lifelong health that starts with the screening by the increasing the awareness. For those of you who are not familiar with what the ACEs screening looks like, this is it. And this is taken from a publication that highlighted how in Kaiser Permanente, Northern California, this was back in 2019, they have been screening in prenatal care for ACEs. So it has been done, it is being done, and it's important that we continue and encourage others to do it. Next slide. If you're interested in finding out more, in reading more about reproductive health and ACEs, we encourage you to read the brief that we published last fall and how ACEs can interrupt and disrupt intergenerational cycles of trauma and improve lifelong health. This is truly an opportunity and a call for collaboration, and we're asking everyone to help us in accomplish this. Next slide. So we talked about how mental health is one of those household disruptions as an ACE, and I want to highlight, and I know that the group focuses on mental health, the data on mental health, with 1 in 5 adults experiencing mental illness each year, 1 in 25 adults experiencing serious mental illness, and 1 in 6 youth age 6 to 17 experiencing a health disorder each year. And the big opportunity that we have, and this is again, if we address ACEs, we bring it in, 50% of all lifetime mental illness starts by age 14. So if we can address ACEs Remember, 44% of mental health disorders could be prevented. Oh my goodness, we could eliminate this. We can really make a difference. Next slide. So what is happening in terms of depression in pregnancy in your county? Well, we pulled up the data, and kudos to you. You are doing better than the state. The state numbers are in the middle there, and your numbers are up on top. You can see the darker colored areas are areas with more depressive symptoms on the left during prenatal care. Your rate is 12.2%, and this data is pulled from the MIHA data that is on the CDPH website, the California Department of Public Health. And you can see also your postpartum rate is 11.6% compared with 14.1% in the rest of California. So keep up the great work. I would not be surprised if this group is responsible for some of these really good numbers. So thank you. Let's continue improving. Next slide. Now, what about by race and ethnicity? And this is 2020 to 2022 data. And I want to highlight the fact that it is incomplete because the ends and the numbers were just too low. But this is just highlights from the data that was available. The prenatal rate between 20 and 34 for depressive symptoms was 12%, and over 35-year-olds, the prenatal rate was 3%. It was 9.5%. Postpartum, you can see the rate. It's actually reversed, right? So we saw a lower rate in the older moms as prenatal, but postpartum, the older moms are higher than the younger moms for the data that we have. And you can see for the race ethnicity for the population that was available, the Hispanic rate was about 18%, and the white rate is about 9% in terms of depression overall. So next slide. And this is California data. So your rates, again, overall, they were less. And California's does have the breakdown by race and ethnicity for the other populations. This is a slide, and we encourage you to please share it, promote it. Addressing the opportunity for folks to be able to do something for a new mom. And what do I mean by that? We oftentimes talk to new moms and say, well, look for these signs for depression, look for these signs if you're not feeling well. But there are loved ones who are surrounding the new mom that they may not be sure as to what they can do. And this is a quick synopsis of what those who are around a new mom can look for in terms of depression. So look for changes in behavior. Are they not showering? Are they not eating? Are they not combing their hair? Listen for harmful words. Are they saying they want to kill themselves, that they're worthless? Provide words of support. You know, you're doing an awesome job. You're doing great. You're a wonderful mom. And more importantly, direct them to places of support. So just helping those who are around a new mom to give them information on what they can do. Next slide. And obviously there are resources from the federal level. There is a helpline that is specific for new moms, postpartum pregnancy and postpartum. And then there's the 988 number that is also available for support. Next slide. And I want to highlight the apps that are available. The Bright Life Kids, that's for parents so that they can know how to help their kids. And the Soluna app is for an individual up until age 26. It starts out with a chatbot. What do you do? You're feeling sad, you're feeling depressed. You get information, immediate information, anytime, 24/7. And if you need one-on-one help from a live human, because it starts out with a chatbot, then the help is provided. You're directed to places of support. And you may be thinking, a chatbot, what is that? Well, I hate to tell you, young people, they feel very comfortable talking to their phone, communicating with their phone, sending texts to their phone, putting questions in ChatGPT. What do I do here? Tell me what to do. So this is very familiar with young people. Next slide. And the final thing I want to bring and highlight is our most recent initiative that we launched, which is One Small Thing, or Un Pequeño Acto de Amor. And what this is addressing the fact, again, remember, my commitment is to decrease maternal mortality. And so we are addressing the fact that over 62% of maternal deaths happen after a mom leaves the hospital, up until 1 year. That 42% of new moms experience loneliness and isolation, and loneliness is the strongest non-medical predictor of postpartum depression. So if this doesn't make you stop to think, what community can do, this is so critically important. We oftentimes think that it's going to be the healthcare team that is going to make a difference in terms of decreasing morbidity and mortality. It really is community. It's community, it's the eyes and the ears surrounding the new mom. Next slide. And so with that in mind, we created One Small Thing. And One Small Thing is really doing one small thing for a new mom. It could be walking with a mom, babysitting, bringing her food, giving her a ride to the doctors, but more importantly, it is being the eyes and ears on the ground and seeing if a mom is not eating, if maybe her feet are swollen, or if she's complaining of a headache and it's not going away, but encouraging her to go to the doctor. So this is so critically important that we all be part of that village, that community that can help make a difference in a mom's life. And the QR code takes you to our website. So please participate, promote it, one small thing. Next slide. If you go to our website, and this is where it takes you, there are coupon books. And I know many organizations have baby showers. I encourage you, print the coupon books. And one coupon is for, I will walk with you. Another coupon is, I will babysit for you. Another coupon is, I will bring you food. Simple things that a mom can exchange for what she really needs. And we can all start to make this part of the norm and really build it into our communities. So reminding ourselves that really the first sign of pediatrics is maternal health, because if we don't help a mom, we're not going to be able to help her care for her baby, care for the rest of the family. So it really oftentimes starts with a mom. And as an OBGYN, I would oftentimes, my heart would break when I would hand the baby over to a new mom, and they looked at me with the eyes and the dad, and they would say, what do we do now? Like I would love an instruction manual, and even now, right, for all of us. So it really does take a village, and we are all part of that village. So next slide. So just leaving you with this thought that pregnancy is a window to future health, reminding folks that if you had high blood pressure in pregnancy, if you had diabetes in pregnancy, if you had depression in pregnancy, that is a red flag, an alert that you have a higher risk for that to continue later on in life, beyond postpartum, into menopause, and as we get older. So let's leverage a pregnancy to improve and to start a better health trajectory. Next slide. So with that, thank you so much for your attention, and I look forward to answering your questions.
Thank you, Dr. Ramos. And yeah, that was quite impactful. So appreciate the data that's even right at home here regarding the impact of the ACEs in our community. A lot to reflect upon and absorb and take in. I feel it in my I feel it in my whole body, the impact of your words. So I just want to open up this space for questions. And I think there might be questions in the chat. I'm going to check right now, and we'll just we'll go. You can raise your hand, or you can put it in the chat, and I'll go in the best order that I can determine. So let's see here. I see a question in the chat from Maggie Kane. So during the pandemic, the years of 20 to 2022, when the prenatal and postpartum depression rates were measured in California, which marks the height of the pandemic, were there any dramatic changes in rates of depression due to that?
The exact numbers I cannot give you. Sadly, we are limited as to how fast we can get the data out, and we are limited to what CDPH collects. So it's CDPH, and the CHIS data and the MIHA data are the ones that collect the information. So what I shared with you was the latest information. I can tell you that during the pandemic, the maternal mortality rate increased by 25% in California as well as nationally. So there was an increase in depression, anxiety overall, because of the stress that the pandemic brought. And as we all know, it was not just social, there was a lot of economic challenges that we all faced.
Another big thing you pointed out was the loneliness. And I think that that's something that just was marked so much by the pandemic as well, is you're already feeling isolated, and then you have, nowhere to go that feels safe anymore. So thank you. I had my son in December of 2020, so I was curious about that.
Yes. And the other thing too, in terms of the loneliness, specifically with the postpartum, is the fact, depending upon the ethnicity of the patient that you're delivering, like in the Latino community, we have what's called the cuarentena, that you're supposed to stay home for 40 days. And if you have a traditional patient that is going to be adhering to that, and I can tell you, my mom said, "You're not going anywhere. Where are you going?" I said, "Mom, I have a postpartum appointment," right? You're going to stay home and you're going to be isolated. And yes, it really is an opportunity, and it's a call. What we're trying to do is call every Californian, like, why not just knock on the door and bring food to a new mom and ask them, how can I help you? And that's why those coupon books are an easy way to say, here you go, here are the coupons. You tell me when you want to redeem them.
Thank you.
Thank you, Maggie. And from Teresa Lagan, what can we do as adults if we have experienced ACEs? How do we counteract the traumatic experiences?
That is a great question. There are a lot of resources that are specific to adults. One, I will make you aware that Dr. Vincent Felitti, thankfully, he has still been very productive in developing programs, resources for adults, along with Dr. Brian Allman, who is his co-investigator in implementing and producing programs that can help adults. The other thing to realize as well is that depending upon where you are and your health insurance, that's where you may want to start out with a counselor. And when I spoke with Dr. Felitti about screening for ACEs in adults, I said, well, where do you start? As an OBGYN, what am I going to do? I have 15 minutes, if I'm lucky, to see a patient. And now I'm asking about ACEs. And he said, and this was very transformative, he said, Diana, all you have to do is listen. And it may not have to be you that listens. It's somebody else in the community, somebody else in your practice, somebody that is just going to listen. And the analogy that he had was, when it comes about to talking about ACEs, people just want to let it out. It's like going to confession in the Catholic religion, and you're not turned back, and you're welcome back. And he says that's all people want to do, is they just want to feel heard, and they just want to release that history. So that is a start. So I know that I'm not telling you go here and call this number, but just know that there are community programs. There are some programs, some church ministries that are doing, not necessarily, they don't call it ACEs, they call it depression, anxiety, mental health. All of these things come into play.
Thank you. And thank you, Teresa. And from Matthew Stone, can anyone get certified to perform the ACEs screening, or do you have to have certain medical certifications first?
That's a great question. Anybody can get certified. Anybody can get certified. You can go on there, and if you go on the ACEs Aware website with the QR code, it actually breaks down the majority of the people who are doing the screening are not healthcare providers. They're social workers, they're ancillary, they're teachers. So depending upon your environment, it really, anybody can do it.
Thank you. So the space is open for continued questions. There's a lot of appreciation happening. Dr. Ramos. Yes, Wendy.
Hi, good afternoon, Dr. Ramos. I'm Wendy Wen, Executive Director at First Five, San Luis Obispo County. It's just so great to be here and hear your talk. I know your background is in reproductive health, and you did a lot of work in Los Angeles County, I believe.
Yes.
I'm interested in both either your own experience as a professional in women's health in Los Angeles, in forging connections and partnerships with your pediatric counterparts, whether that happens or doesn't happen, and what your thoughts are on that sort of continuation, that continuity of care from pre to postnatal, as well as community-based supports around the outside. But I thought, just to make the question simple, the OB or midwifery space, the prenatal to postnatal and early childhood space, what is that in your view?
So I thanks, Wendy, for that question, because this is an opportunity to highlight us here in California, specifically with dyad care. So in California, we reimburse, Medi-Cal reimburses for dyad care, which is very innovative and very different. So if a pediatrician goes to see, if a mom goes to a pediatrician and brings her baby, right? Because we know that oftentimes moms will keep their other appointments for their babies, but sometimes not for themselves. The pediatrician can actually do a depression screening. The pediatrician can actually make a quick assessment, and they can actually bill through the dyad care, through the outpatient care. So California is a trailblazer. This is not what happens nationwide. The challenge, and I was speaking with somebody from a managed care plan yesterday, is how can we leverage those babies in the NICU? How can we leverage the screening of a mom and a dad, right, if they're in the NICU? Because oftentimes babies who are born preterm, the mom or the dad are visiting and they're there. And again, they may not be going for their own personal health and following up for their health. They're there for the baby. So we were trying to piece it out together. And, how can we get the hospital team to get reimbursed for doing a depression screening in the mom and the dad, doing a depression screen or doing a blood pressure check also. So these are opportunities. Depending upon the situation and the healthcare setting that you're in, Wendy, it's not always so easy. And I can tell you that the majority of the time, maybe depending upon whether or not you are an electronic medical record that you can communicate directly and you know who the pediatrician is or the OB is for the mom or the baby, you can send a message. But most of the time, that's not the norm. I think the biggest opportunity would be with the pediatrician providing that dyad care. But know that California does reimburse for dyad care, and that is a huge win for Californians.
Thank you, Wendy. So there is a comment and a question from Captain Pat Friendship. I have a program that directly provides positive experiences through community engagement for Black and Brown families. How would I share my program with these families?
Hi, Captain. I think we have been on a work group together. All Children Thrive, I want to say. Great to hear your question. And I would say start locally. Start locally with some of the partners there in San Luis Obispo, maybe even First Five, Wendy, who was on there, and be able to distribute the program through them.
All right. All right. We're still open. We have plenty of time for questions. I guess I would like to ask the question of I mean, you pointed to it, Dr. Ramos, in your presentation, but there are a lot of obstacles going on currently, but there's, what do you see as the next frontier for trauma-informed care in California? Would it be the pediatric prevention realm, or what's the next frontier to keep it alive and viable?
I honestly think it is with the reproductive age people, because that's where everything, right? Oftentimes, if you can have a healthy mom or a mom that is getting the care that she needs to help move forward, then from what happened in the past, she will be healthier and better mentally to help her baby, to help the rest of the family. I appreciate the efforts that have happened in the pediatric, in the child arena, but what ends up happening, and I heard this from some focus groups with Native youth, is that, I went to this program, it was great, it was awesome, but then I came home and my cousin who does drugs, my dad who abuses my mom, and it just kept on going on. I just came back to that environment, and everything that got better or I thought was better, I just went back into that environment. So if we can make a difference in the home, we can make a difference with the adults. I think we can make a difference going forward for everyone.
And as you said, it sounds like it mitigates the epigenetics right there. All right, everyone. Any more questions, comments?
Well, thank you so much for the opportunity. It was wonderful to see some familiar faces, and thank you for all of the work that you are all doing. Truly appreciate your partnership. Thank you.
Thank you, Dr. Ramos. And I think from here, we're going to transition to Rebecca regarding for our closing.
So this has been a lovely time to spend together. Thank you, Dr. Ramos, and all the work that's been done to bring us all together to have this time and reflect. The ACE study is a pivotal place for us all to continue to reflect on and be aware of, and how our day-to-day interactions are very important. And we are all in a place of preventative with each other all the time in terms of our relationships. We can all be there for each other. That's still a thing. And I thank you all for your time. So wonderful turnout. Very much appreciate it. Our next meeting will be the 29th of March. And we are in the process of scheduling a presenter, so that information will be coming out soon. Please pass this along to other people who are like-minded and who are interested in, networking with others in our community. I mean, when you see this number of folks show up for a presentation, it just shows how vibrant our community is in terms of being there for each other and the community that we serve. So please come back. Please share the word. We're still working on growing. If you're interested in any kind of assistance to us, then let us know. Barry and myself and Michelle. And we are very, very glad that you are all here today. I wish you the best moving forward and hope to see you again. Take good care of yourselves, okay? Thank you so much.